how do you differentiate heat stroke from heat exhaustion and other causes of hyperpyrexia? In our last video, MRCEM SBA Challenge 63 Part A, we discussed a case of an elderly gentleman presenting to the emergency department during a heat wave with a GCS of 9 and severe hypothermia. If you missed this video where we analyze the physiology and the case history, make sure to click the link in the description below. Today we are going to systematically rule out other options and dive straight into the emergency management of heat stroke. Let's pick up right where we left off. First, we will discuss why the other options are wrong. Option A, heat exhaustion. In heat exhaustion, the core temperature stays below 40 degrees centigrade. Sweating is usually profuse and crucially, CNS function is preserved. The patient might have a headache or nausea, but they are not comatose. Option C, septic shock. While sepsis causes fever and low blood pressure, a temperature of 42 degrees centigrade is exceptionally rare in a typical infection. The context of a heat wave and his dry skin strongly point toward environmental hypothermia. Option D, malignant hyperthermia. This is a true anesthetic emergency triggered by volatile gases like sevoflurane or succinylcholine. It happens in the operating theater, not at home. Option E, serotonin syndrome. This requires exposure to serotonergic agents like SSRIs or MAO inhibitors. While chlorpromazine can cause something similar called neuroleptic malignant syndrome, this condition develops over days and feature classic lead pipe muscle rigidity. Our patient's presentation is acute and perfectly tracks the weather. Now the management of heat stroke. If you encounter heat stroke in the emergency department, you have to act instantly. Here are the three non-negotiable management principles you need to be aware of. Number 1, immediate aggressive cooling. This is a true race against the clock. Above 41 to 42 degrees centigrade, the essential proteins in the brain literally begins to denature. Your goal is to rapidly bring that core temperature down to 39 degrees centigrade. For classic heat stroke, use evaporative cooling by spraying the patient with lukewarm water and using powerful fans. Ice cold immersion is fantastic, but usually reserved for younger patients and exertional cases. Number 2, absolutely avoid antipyretics. Do not give paracetamol or ibuprofen. These medications work by lowering a hypothalamic set point raised by infection driven cytokines. In heat stroke, the set point is completely normal. The body is just physically overheated. Giving these drugs won't help and can cause severe liver injury. Number 3, cautious fluid replacement. The patient is hypotensive, but remember his age. Rehydrate cautiously to avoid tipping an elderly patient straight into acute pulmonary edema. And this completes our deep dive into mastering heat stroke. Now you know exactly how to manage this critical emergency under pressure. Please drop any questions you have in the comments below. Hit like and subscribe, and I will see you in the next video.